So Renu, we're in Doha on the way to the EAU.
It's incredible, yeah. 14 hours later, we have reached Europe. No, we haven't.
Not really, nearly.
I don't know where we are.
So we left Melbourne Tuesday night, late. It was nice there. We'd only just been to USANS, but we went and did a day's work and then hopped on a 14-hour leg to get up to here, to Doha, which is very nice. Qatar Airways.
So good.
If you want to plug, give it. We can give you a plug. Please give us free things.
Yeah.
They're great. They've just been
conditional.
voted the world's best airline, and this is the world's best airport here in Doha. And I think they're really getting ready for the World Cup, actually. So anyone lucky enough to be coming to the World Cup, you're going to have a great experience. I think the Qataris are putting on a fantastic show, and this place is just amazing.
And their hospitality is just evident in every little thing that you do, right?
Exactly
it's
right.
incredible, and this lounge is spectacular.
Oh, come on, we are working it. We've got to get to the
EAU
now.
We
so
are,
they've just filled up the tank of petrol in the airplane, and we're going to hop on and go 7 or 8 hours up to Amsterdam.
Yep.
Get there today. We're meeting some of our friends. Matt Cooperberg is meeting us later on. We're going to have a chat. We've got some meetings already when we get to Amsterdam, and then EAU kicks off tomorrow. Lots of great stuff, and we're looking forward to bringing some highlights, I think, on the podcast.
Yeah, it's going to be a great meeting, and we're looking forward to catching up with some friends and colleagues, and we've got some merchandise, so we're looking forward to handing them out. One suitcase is all merchandise, by the way.
It is. It's
going to be exciting.
We're going to find somewhere on Friday evening, some Irish bar inevitably. Friends of the podcast, come and track us down, and you might get yourself a polo shirt or a baseball cap
or a hat or a beanie or something. Yeah, it'll be good.
All right. Let's go.
Let's get on the plane.
Bye.
Okay.
So, welcome to Amsterdam.
Welcome to Amsterdam. It's EAU 2022, and we're in sunny Amsterdam in spring.
So, to celebrate the end of COVID, at least for now, we hope, we are bringing you another conference highlights, and this from my personal favourite urology meeting, which is the EAU Annual Scientific Meeting, and it's going to be a great few days.
And my first EAU, and my first time in Amsterdam. It's going to be fantastic.
It is. So we're going to bring you the flavour of the meeting as usual. It's a huge meeting, of course, so we can't bring you everything, but we're going to chat to a few people who are presenting here and just a few delegates, and we're going to have a little walk around Amsterdam and get a flavour of this fantastic city as well. Yeah,
lots of science to look forward to, lots of fun, lots of amazing sights, and I hear good food as well.
And we're going to have the inaugural GU Cast drinks reception to show our appreciation for all of you listeners and viewers out there who support us, and of course some of the guests who come on the show, because quite a few of all of the above are here in Amsterdam.
Yeah, we've got a lot of friends of the podcast here, so we've got some GU merchandise to give away, and it's going to be a fantastic inaugural drink section, I think.
All right, let's hope you enjoyed this episode. Please do send us feedback as ever.
See you later. All right, hello everyone. We are here not at USANS, but EAU 2022, all the way in Amsterdam in the Netherlands, and it's day one. It's insane. Have a look at the trade hall behind me. But the focus of right now is actually, I've got two very important KOLs with me. Actually, when you look, it's a star-studded performance, but I managed to grab these two. We've got Jim Catto and Peter Black. Welcome, guys.
Great to be here. Nice to see you guys back in the continent.
Yeah, thank you. Lovely to be here. Thank you.
And I really should be asking them how they're doing after the travel, but I might actually ask them how they're doing after the pub last night. Jim?
Well, I wouldn't know.
I'm here with wife and children, so I wouldn't know either. So.
You guys are behaving. Jim, over to you. You were in the 7:30 plenary this morning. Tell us about the highlights.
Well, you were there, Renu, so what did you find about it?
This is not fair. They're not interviewing me.
So we were presenting IROC this morning, which is our robotic trial. As you know, now published in JAMA, so we saw a 2-day difference in length of stay between complete intracorporeal and open surgery. It's all about quality of recovery, isn't it? So in the first 90 days, robotics, less disability, better quality of life, but probably more expensive, so it's that trade-off. What we didn't expect to see was 4-fold fewer DVTs, pulmonary emboli in the robotic arm. So that's something about mobility, and that is for us, that was a real game changer, because if you can reduce the DVT PE rate, and it was mostly PEs, from 8% to 2%, that's quite a safety thing, isn't it? And in fact, we did have an open death from pulmonary emboli in the first 90 days. So.
Wow, so very interesting results, and we love randomised trials, and it truly deserves its place in the game-changing session, so congratulations, Jim.
Thank you.
And Peter, welcome to EAU. I've got a microphone. These, again, tall guys. I mean, seriously, my arm's getting a workout. What can we look forward to in bladder cancer at EAU 22?
Well, I think this was already probably the highlight, and I think Jim and colleagues deserve a lot of congratulations for pulling off this trial, and I think it is practice changing. I think there are a lot of people who will criticize the endpoint, how clinically significant is that, but I think we all know, or we all see that robotics leads to quicker recovery. It's just very hard to measure. They've measured it, there's a difference. I think it's enough to justify. In North America, the cost of robotics isn't really an issue.
Yeah.
It's done regardless. I think it's probably the same for you.
Yeah.
So I think it is game changing. Otherwise, I think, I mean, there are a lot of little things in the poster sessions and whatnot that I'm keen to see. It's going to be fun interacting with the junior faculty the first time, junior urologists for the first time in a couple of years in person. So it'll be a good meeting.
And tell us how things going at the SIU Journal. You know, it's gaining a lot of momentum since it started. Is it going well?
Yeah, it's growing. It's always difficult to be the new kid on the block. Everyone wants to know, when is it going to be PubMed indexed, when it's going to get impact factor. Yeah. Jim just got his impact factor of 24. I think we're a few magnitudes off that when it comes. But it's growing, so it's good.
Fantastic. Well, you boys have a wonderful conference, and we look forward to catching up with you soon.
Great, thank you.
All right, here we are. I've got a very important guest. It actually took a while to track him down and pin him down for an interview. But Tim O'Brien, he really needs no introduction. But welcome, Tim. How are you?
I've never been described as important before. I'm not sure I am. Unimportant. A very unimportant guest.
Oh, really?
It's a very small world in which to be minorly important. Anyway.
Well, we think you're important, and you were in the early morning plenary this morning after getting in very late last night. And we always think that you're a fantastic speaker. You really engage your audience and tell some great stories. And you gave a great presentation this morning about challenges in advanced renal cancer, managing cable thrombi. You know, we could see the audience. Everyone had their cameras up. Everyone was taking photos. It was a great presentation.
Well, thank you. It was fun putting it together. Yeah. I mean, some talks you don't really get a huge thrill putting them together. It feels like work. Yeah. And then some talks don't feel like work, do they? They just feel like you're telling a story. So that was a fun one to put together.
And you know, one thing you always say is don't let the important messages drown. And so you had 5 tips, 5 warnings in 5 minutes. We love that at GUcast.
Are you going to ask me what they were? You're asking me to remember my talk.
I am going to ask you to remember your talk.
What I teach people who are coming up to Vivas for the FRCS Urol is never give a number. Yeah. So say there are several, because then if you don't remember the number, well, if you say there are 5 and you only remember 4, the examiner always says, well, what's the 5th? So they only ever remember the one you didn't remember, where I say there are several reasons for this, and then they never know whether you were thinking of 4 or 5.
That is true. So
there were several
number of tips. Yeah.
Several tips and several warnings. Yeah. Okay. Well, the first tip was operate with the same team. Yeah. And I place the emphasis on same. This is often multi-surgeon operating, urologist, HPB, cardiac. And I just think it's really important those individuals are the same, so you build a trust and you build a rapport. And actually you learn from each other. I've learned a lot of surgery from the cardiac surgeon we work with and from the HPB surgeons. And I think they've probably learned a bit about urology from me too. So I think it's got to be a teamwork involves the same people delivering it time in, time out. So I think that was the first lesson. It was unashamedly an organisational lesson for the first lesson. And then there were some technical things, some radiological things. In the NHS, delays are endemic. Yeah. So obviously illustrated one of the problems about having imaging delays. Tumours progress. These aren't indolent tumours. They move through the cava, move towards the heart. Some of the patients demand more urgent action than others. I think that's a very important thing to understand about all clinical situations. Does this really, really need urgent action, or does it, is it something that can be just temporized for a while? And we think that IVC tumours that are embolizing need urgent action because there's a risk of a fatal embolus before you move. Yeah. And then some of the things we've learned about this, the most important lesson in the surgery, I think, is to isolate the blood supply to the kidney before you do any dissection. We've totally changed our technique. I've been a consultant since 1999. We do it a totally different way from how we used to do it. I think sometimes people think that technique only evolves through laparoscopy and robotics and the technology. I think open surgery also improves. And we've been relentless in our attempts to try and improve our open techniques too. So we go straight onto the aorta, We find the renal artery, slide off the aorta onto the renal artery and ligate it, close down the blood supply. It's particularly important when the venous drainage is blocked because, the collaterals are high pressure. And then the final, the tips, the cardiac tips, knowing who to operate on and who not to operate on. So I showed a picture of I can tell her name, she doesn't mind me telling her name, Alice Chadwick, who is our 95-year-old, who I sent back to Kent saying, "You're far too old to have combined kidney and cardiac surgery." And her daughter contacted me and said, "My mother doesn't want to sit in Kent waiting to die. She wants an operation." And so we brought her back to London and operated on her, and she was absolutely fine. And so she was one end of the spectrum. And then the other end of the spectrum is the people who you shouldn't operate on because they're probably going to die anyway. They just are decompensating. Yeah. So those are some of the tips, some of the warnings. Were there any others? I'm not sure were there any others. I think there might have been, but I can't remember them.
There you go, folks. You don't have to attend the EAU plenary. You just listen to our podcast and you'll get all the main messages anyway.
But I'm sure that, those are my reflections on what I do.
Absolutely.
I'm sure if you went in and did reflections on RARP, if you did reflections on cystectomy, PCNL, I think that's, I think people over-obsess about the learning you do during training. A lot of my learning has been post-training, as a consultant.
Absolutely.
And I think trainees need to understand that the training period is one point in your learning and the learning doesn't stop. And I think it can't stop. It shouldn't stop.
Well, I think learning happens when the weight of responsibility is on your shoulders.
A little bit. But I think the other thing is that I think when you work with a referral practice like we do, I think you have a responsibility to improve and then share that learning, don't you? So we've got better because people have been kind enough to refer the cases. We've demanded that improvement of ourselves, and we definitely have improved. I mean, there's no question we've improved. And what I haven't worked out yet, and a lot of people have asked me what I'm going to do following BAUS, and I've been BAUS president for the last couple of years. One of the things I'm going to do, I am going to try and create the world's best archive of filmed open surgery in urology. Declan and I, a long time ago, developed the world's best archive of blue light cystoscopy and 2RBT. It was amazing to do that. And I just think we haven't woken up to getting really good filmed evidence of good open surgery. It's quite difficult to do.
Absolutely.
But so that's one of the things I'm going to try and do in the next year is get really, really good film of good and bad surgery. Some of the things, just like stopping bleeding. How to stop bleeding. Because it's so important to do it right. There are different techniques.
Nothing like an amazing video library for sure.
Yeah, sure.
But you've just touched on something that we should move on to, and it's that you're the immediate past president of BAUS, and we remember having you on GUcast a while ago, and you talked about your vision for your term as president.
Oh, right.
And now you've handed over to Joe Creswell. So your thoughts on how things have gone in the past couple of years and how you expect things to progress in the future?
I've enjoyed the 2 years. I enjoyed handing on. You put a lot... I was a sprinter jumper when I did athletics, so I tended to go hard and then rest. And that's a slightly similar way managerially. I'm not really a 10K runner who just sort of grinds along. I was happy to hand on. I'd enjoyed the 2 years. It'd been quite hard work. And I think in terms of what we managed to do, you have some things that surprise you how well they went. Some things went as well as you thought they would, and actually some things never got off the ground. And that's the way it is. And I don't dwell too much on those things. You never get. And some things, you had to deal with that you weren't expecting at all. They came completely out of left field, and they needed dealing with. We finished with an unbelievably enjoyable Congress. There was a tremendous vibe. It made you just thrilled to be a British urologist at the British meeting. There was a really amazing vibe. I think we'd really changed the tempo and the feel of Congress. And that felt like a very valuable thing to have done. It was a really, really good... I think one of the criticisms of organisations that run events is that it can be same old, same speakers, same subjects, same thing.
Absolutely.
And we really tried hard. Ian Pearce, who curated the meeting, did a really good job. And I don't think anyone could level the accusation at us of same old, same old. So we had a lot more young urologists talking, a lot more women, a lot more people from less fashionable units. And I think that was good. A lot of people came up to me and said, Tim, it felt very different. So we were very proud of that.
Well, you've done a lot for diversity in urology, so I mean, we could talk forever, really, but we're going to let you go, and it's been fantastic to see you at the meeting. Congratulations on everything you've achieved as BAUS president, and we look forward to seeing more of you over the next few days.
Enjoy Amsterdam.
So guess who we bumped into here at EAU in Amsterdam? One of my favourite pathologists in the whole world, Dr. Eva Comperat. Eva, nice to see you.
Yeah, it's a pleasure to see you, both of you.
So Eva is a uropathologist, head of the uropathology department at the Medical University in Vienna. Previously in Paris, of course. Yes. I remember when we first got to know you, you were in Paris, but you are Austrian, I think, by birth, and and you're always at the EAU. You're such a key opinion leader in GU pathology that the big meetings like EAU are always very pleased to have you here, involved in guidelines and courses and debates. Great debate yesterday, and we thought we'd pick your brains for a couple of minutes for our urology audience, just with some key messages about GU pathology, because it does move on a bit. You know,
it does, yeah.
It's moved on, and I remember doing a talk recently about prostate cancer pathology. Would you believe I was asked to do a talk on this? And I was reflecting back to when I started doing urology, and prostate cancer was just Gleason score. That was it. It was very simple, wasn't it?
Yeah,
but I wanted to first of all ask you a bit about prostate. One of the things that I see coming up all the time is, for example, how important it is that we recognize these subtypes, these pathological variants, like the presence of cribriform, IDCP, ductal. We now recognize as urologists that these things in particular, cribriform, IDCP, ductal, when we see them on a pathology report, it's important. So I thought we might pick your brains about those three in simple terms for us.
Okay, so
you go borrow my microphone there.
Thank you. Well, there are several things. First of all, cribriform has to be mentioned in the biopsy report and also in the report of radical prostatectomy, because we know that these people have more often biological recurrence. They have, in case of radical prostatectomy, higher incidence of metastasis, death of disease, positive margins. So all these adverse events which you can see. And this is really a recommendation since 2019 that it has to be in a report. So if it it is never mentioned in a report by your pathologist, please ask him why he doesn't do it. The same is true for intraductal carcinoma. The problem with intraductal is, well, we know that most of the time intraductal is together with invasive tumor. It can be pure. In this case, it should not be graded because it's not invasive. It's a little bit like carcinoma in situ, but with prostate cancer. But personally, I have never seen an intraductal only, intraductal and without. I think it's 0.03%, something like this. So of course, cribriform, we have problems. There are two papers, one from ISA, from the International Society of Uropathology, the other one from GAPS, which is the Genitourinary Pathology Society, to have a kind of consensus what we really should call cribriform. Apparently, there is a kind of observer variability. But I think it's getting better, and if it's really typical, everybody agrees. It's not just like these atypical things where people do not agree. The second thing is WHO 22 will be released. It has been printed. I think it will be released in September, something like this. We're a little bit late. And there are, in the acinar adenocarcinoma, which is the most frequent, we have now these histological subtypes. So aspects which are not usual. Most of them are not very aggressive, but the real subtypes like pleomorphic, signet cell rings, these are really very aggressive tumors, and these are patients also, like with the cribriform, who should be tested probably, because we know very often, for example, in cribriform they have these BRCA mutations. Yeah. And the problem is, shall we test all of them or not all of them? So this is a real debate. So be aware that if we talk about subtypes in the prostate cancer, very often these are aggressive tumors, and this has to be mentioned too, of course, in a pathology report. I think that's very important. And ductal, of course, is high grade, is always Gleason pattern 4. It's pretty rare. It's pretty complicated to recognize on biopsies, by the way. But nevertheless, of course, if you see this in a report, you know this is a high-risk patient.
And very often it's not pure ductal, it's not that classic endometrioid, it's this mixed adenocarcinoma and ductal. But we know even with that, even with a proportion of that, it does portend a poorer prognosis, so important to recognize. On the cribriform, I think for urologists, one of the simplest important messages about that is if you have a favorable intermediate risk patient, it's a patient with grade group 2, 3+4, maybe relatively low percentage pattern 4, sometimes we think maybe this is a surveillance candidate, but the presence of cribriform should be a red flag in that. So I think that's one of the most important things about recognizing it, and as you say, making sure it's on the synoptic report and so on, because I can tell you for sure, in very many instances, cribriform is not specifically reported separately, and sometimes from certain pathology labs we have to actually go back out or get the slides in to say, is there cribriform or not, especially if we're thinking about surveillance. So do you think the message is getting out? I mean, things like GUPS or ISUP, which by the way don't always agree, I've recognized as well. Who holds sway here? Is it ISUP or GUPS?
Keep to the WHO. Keep to the WHO. No, I mean, I would also like to refer to ICCR, which is the International Collaboration on Cancer Reporting. So it's ICCR Cancer Org, and they have all the synoptic reports and all you should find in a report. So if you don't find it, you can go to your pathologist and say, come on, why don't I have this and this and this? But there's also clinical information, I just tell you, in our synoptic reports, which is for us, of course, very important too.
Exactly right. And you should follow Eva on Twitter, because she does tweet out valuable stuff like this, and as do her excellent colleagues in the GU Path community. But Renu, you wanted to ask her a little bit about urothelial cancer.
Absolutely. I mean, that's one of your other passions, Eva, is urothelial cancer. And I think urothelial cancer, we all recognize that it's one area where you really need the involvement of the pathologist.
I think so.
And the knowing the correct staging and grading of tumor really influences your decision making for that patient and how that patient does on that treatment. So what is the latest? You were just in the non-muscle invasive bladder cancer EAU guidelines sort of debate.
Yes.
And there have been some changes in the classification of non-muscle invasive bladder cancer. And tell us about that session that you were in and what we can take away from it.
Well, at the very moment there is a very big debate about grading, because grading has become extremely political, unluckily. So there are people who really push forwards to have a 4-tier grading system. The others say, well, pan-lump, low grade, high grade is perfect. It's especially in Europe where they want to have this 4-tier grading system. I was just asked to write a kind of editorial about what is done, where it is done, and so on. I think we have to step a little bit back, because you cannot ask us urologists who have WHO, ICCR and CAP recommendations worldwide, where it's low grade, high grade, to ask us to make a 4-tier grading system, which is recommended, of course, by some people, but it's not an official statement, an official organism. So I think this is really something which has to be sorted out within the next 2-3 years.
Yeah. And what about variants of bladder cancer? That's the other sort of contentious issue, really, isn't it?
So it's now subtypes, by the way, WHO. So everything which is surgical pathology is subtype, and everything which is molecular is variant. I think that's pretty easy to mention now for people. So if we talk about variant, well, everybody knows it's molecular. Well, it has not changed so much in the bladder. It's pretty the same. But the problem is, of course, what are we doing with these patients who have, let's say, 10% of micropapillary and 10% of, nested, and the rest is classical urothelial carcinoma. We still do not know very well what to do with them. So our recommendations in surgical pathology are, of course, to be as precise as possible, because you have the patient in front. And you will decide, well, if this is a guy who is 85 and he has kind of 10% of micropap, you will not be as aggressive probably as if it's the patient who is 50. Absolutely. So it's really up to you. So we have to give you the most important information, like carcinoma in situ, whether it's multifocal, whether it's big. Of course, the staging, substaging of PT1 is still under debate, because we do not have very good head-to-head data at the very moment, but should of course be done. And all these kind of things, lymphovascular invasion, whether there is a subtype, yes or no, especially non-muscle invasive, I think it's really important, and it's really underestimated. And afterwards, it's up to you what you are going to do with the patient, because we don't see him.
It's a truly collaborative effort, isn't it? And I think that's why at Peter Mac also we really embed the uropathologist in our multidisciplinary meetings and discussion. And we're very fortunate to work with Catherine Mitchell at Peter Mac, who's just brilliant.
Andrew Ryan and colleagues at Tissue Path.
Absolutely.
But isn't that one of the key messages? That it evolves. It's very different.
It is. It's work in progress.
And because it's very sophisticated now, and these subtypes and variants and nuances in reporting do feed into how we should manage patients. So I think the message is we need to really work closely with our uropathologists, and it can be a challenge. You're on the Lancet Commission, the Prostate Cancer Commission coming out this year with Nick James, and I know in many of the discussions on the Lancet Commission on prostate cancer, which is look at the totality of prostate cancer across the globe, the challenges are in very many regions we don't have the EVAs of the world, and people are managing enormous workloads of pathology. So I suppose a question on that is the role of AI and machine learning to help
well,
people.
in prostate it works pretty well, I would say. I mean, it's it's a question of costs, and it's a question of the workflow in the lab, whether the lab can first, of course, afford, and second, make it work. It works in the prostate really very, very good. On the other hand, in the bladder, it's still under, we're trying to get out the best. Kidney is extremely complicated, but prostate, we have very good heat maps, we have very good relationships, and sometimes the machine does even better than the human.
There you go.
Yeah.
But you're not quite obsolete.
No.
Well, you're a wealth of information, Eva. We love chatting with you. Are you planning to come to Australia anytime?
Yes, I will be there in October.
Fantastic.
Yes, in Sydney.
Well, we'll have to go and visit her.
We'll have to.
Come on to us, come to Melbourne.
Okay.
Absolutely, yes.
Thank you.
We'll have to make that happen. So, Eva Comperat, brilliant as always.
Thank you very much.
Another excellent initiative from EAU this year is EAU TV. They've set up a fantastic TV studio in the middle of the convention centre and are producing excellent short programs focusing on hot topics.
15-minute conversation, give or take.
Stylish. Yeah, we can do that. And should I look?
Yeah, don't look at the cameras. Just look at each other. Like act like the cameras aren't here, except when you're introducing and saying goodbye. Otherwise,
I need to take some footage of all your kit, though. I got to chat with my mate Chris Sweeney along with host Alberto Briganti. Look at the professionals that are watching my YouTube channel. Welcome to EAU TV. We're coming to you from the studio here on GUcast. I'm joined by my friends, Dr. Chris Sweeney.
Chris Sweeney, a friend of Declan by default, and I will always try and over-promote GUcast like Declan over-promotes GUcast, but really go to your amigos.
Moving on quickly to Dr. Briganti.
Hello, how are you? Good to see you all, and I'm happy to be here with these crazy guys. Ladies and gentlemen, welcome to this edition of EAU TV.
I would still do curative radiation therapy, let me be very clear.
Not surgery.
Not surgery, because...
Taxi for Sweeney. Taxi. This is a urology meeting.
I pay for it.
Yeah.
Look at the tweet. I was called the Pope by Gianluca today.
You can find the full program and more on the EAU channel on YouTube. And that's all we have for you on this episode of GUcast. We'll be back in a few days with part 2 of our conference highlights from the EAU meeting in Amsterdam, including discussions with Maria Ribal, David Boucher-Hayes, and a bunch of GUcast regulars who joined us for a drink at the GUcast reception in Amsterdam. Take care and see you soon.